Hello, everybody. Really quiet, so I thought I'll have to speak. Can't stand silences. Looks like we've got quite a few people joining. Nice to see some lovely faces that I already know and some new ones. Paul, you're on mute. Paul Latimer.
Thank you. We'll start that again, shall I? So thank you everyone for joining. My name is Paul Latimer. I'm the clinical consultant team lead here at Nerve Centre. Some names and some faces that I recognise, some that I don't. I'm sure I'll get to know you more as the months and years progress in my career at Nerve Centre. This is the second of our COVID webinars that we've now hosted. We hosted the first one during the first wave, and got some really positive responses to that. And we were asked if we would be able to put on a second webinar by some of our customers as well during the second wave to share some of the work and the positive work that's come out from some customer sites to share with other people.
Hear me?
Yeah. I can hear you, Jeremy. Yeah.
Sorry, I've got to go because I've got a patient that's got surgical emphysema and he now can't open his eyes.
That sounds reasonable to me.
I'll hopefully be a few, like 10 minutes.
It's fine, Jeremy. It's fine. You go.
Debbie, what I'll do, I'll email my screenshots around, okay?
Yeah.
Just to you to share, okay? All right.
Yeah.
Right, so that's the first. That was going to be item number 1 on our agenda today. That's absolutely fine. Other things take priority, don't they, from that perspective? Kate Ward, are you doing this piece on photography and PPE?
I'm doing something on photography, which I've just pulled together this morning. So I'm happy to share that. It's a bit impromptu, but hopefully it'll tick the box.
We like impromptu. So on our agenda today, there's a few things on the agenda today that we're going to discuss. We'd like to let our customers share and talk some of their experiences. This is very much, although there's an agenda, it's very loose, it's very fluid. Ask questions, talk amongst each other. That's what we really want to get out of this, is to share those experiences. So we're not going to go to Nottingham first. We're going to go across the Midlands a little bit further to Kate Ward, who's a matron for health informatics to that extent through at UHL, who will share a bit of work what they've done around clinical photography and PPE. So Kate, over to you to start.
Okay.
Paul, can I just make sure? Is it being recorded? You got it on record?
Well, good question. Christina, can I leave that with you?
I've asked Tracy, but it should be automatically recorded.
Brilliant. Sorry to interrupt, but just make sure because I promise that those can't end, that we will send a recording.
No, that's great. Thanks, Jacinda.
Okay, can everybody see that?
We can.
You can. Okay. So I've just been asked to talk a little bit about how UHL used clinical photography during the first COVID wave. Our teams were very quick to recognise that clinical photography was going to be able to help to support them. Can you hear me? Yeah.
Loud and clear.
Yeah. We had a number of teams who utilised the clinical photography function, and it enabled them to undertake remote reviews of patients. And these patients are the ones that were in the hot zones, and that, of course, reduced the need for them to actually go into these hot zones and unnecessary exposure, I suppose, but also to preserve the precious PPE stocks that we had for the people who were actually working on the shop floor clinically for these patients. So pharmacy were one of the first to actually approach us about it. And what we did there was we quickly pulled together a sort of SOP to provide some governance around this. And they took images of medication charts. Well, the nursing staff took the images actually. And then the pharmacy team reviewed these remotely in Nerve Centre. And then they involved microbiologists where necessary, and the clinical teams like the medics, to be able to communicate any changes to regimes that were required. The dietetics team was another team who did the very similar thing, taking images of their enteral and parenteral feed prescriptions, food charts, and they also looked in Nerve Centre on the fluid balance, which we have live, to be able to look at how best to treat their patients, help support the clinical teams on the shop floor to provide nutritional care. And they actually won an award, is it the BAPN Awards, for the way that they innovatively changed their working practice during COVID. So that was really good. The next screen. Clinical audit was another team who, again, got nursing staff on the shop floor to take images of charts, progress sheets, particularly in ITU, so that they were able to capture all the data they were required to report on, and particularly the ICNARC data for ITU. They managed to continue to deliver their reports on time as they did pre-COVID. ECGs are an interesting one. So prior to COVID, we had in place the ability to use clinical photography in ED to take images of ECGs. Our cardiology clinicians work on a different site to ED. So as part of a referral process, the cardiologists were able to view the ECGs in Nerve Centre to be able to advise on management of these patients. But particularly during COVID, it was useful because we were trying to work out how best to place patients, because of all the displacement of specialties as a result of trying to keep positive and negative patients apart. I would add that I know Debbie would want me to add this, that this isn't how it's a workaround almost. So the photographing of ECGs isn't something that is long-term plan of ours to manage ECGs, and we're going to get some integration of ECG machines into Nerve Centre so that they can be the details can be seen properly. But this is something that has really benefited our teams and our patients at the moment, and particularly during COVID has been very helpful. So that's really all I've got to share on that, but I'm more than happy to take questions if anybody wants to ask anything.
Hi, it's Sue here from Doncaster.
Hi, Sue.
Hi. We've got the photography module of Nerve Centre. However, we've not actually implemented it yet. And I was just wondering how you got around the whole kind of safety element of it, really, in terms of governance and all that side of it, really.
So, in what way do you mean? So, from a consent perspective, a field clinical photography consent.
Yeah.
So we have to get the consent of the patient to take images. Obviously, when you're taking images of charts, that's different.
Yeah. So I'm just thinking about sort of how you got it all signed off within the trust that you were then able to use that module. We're just struggling a little bit to take it forward, really.
All right. Okay.
So would it be worth, so it's Debbie speaking, would it be worth picking this up with the leads at Nottingham and Leicester offline? I'll put you in touch with them.
Yeah, that'd be great. Thank you. Yeah, fantastic.
Because Nottingham are also live with with the camera, as are Northumbria. So if we take an action, and we'll put you in touch with all three, and then you can check what their governance, how they've introduced their governance and got it signed off.
Yeah, that'd be lovely. Thank you. Yeah.
And then hopefully we could use that for other customers. We've got it's taken the camera, so yeah, I'll take that as an action.
Thank you.
We've got an SOP we can share with you as well, if that will help. So.
Oh, that would be fantastic. Thank you very much. Yes.
Cool. We'll make introductions after.
Yeah, I was just making all those notes there. Take myself on mute. I'll absolutely make those introductions to get those things together.
So I'm gonna. Paul's running this session, and I know he is, and he is used to me talking over him now. So just that I've done a bit more with the planning. So we've got Steve Canslow and Mark Simmons on, and we've got the slides from Jeremy. I wonder if one of you could fill in the next 10-15 minutes. If you are, you're on mute.
Hello there. Hi.
Hi, Steve.
Is Mark here as well? I didn't see.
His name's on the his name's as a participant. I have got the slides that's got some hospitalised stuff on if you want them up. Steve.
Oh yeah, no, let's put them up. Sorry, Jeremy invited me at the last moment to the meeting, and I'm afraid I'm clinical today, so forgive me for my lack of prep. But I'll introduce myself. My name's Steve Canslow. I'm an intensive care consultant in Nottingham. I also head up Hospital at Night as well. And I think the thing that I'm speaking about is our introduction as well of Hospital at Day, which is a COVID innovation, but something that we think will last beyond COVID. In that, and what it allows us to do is leverage a lot of the capabilities of Hospital at Night in the daytime, but particularly using nerve centres, task management system, and so the whole concept of getting the help where you need it when you need it, it can be something that's absolutely really useful in the daytime. When you're short of staff and when absence is very high, and you've got wards flipping to COVID throughout your organisation. So it's something that we found really useful. We've also updated the live flow. We've introduced a feature onto the live flow pages, so that we get a global view of tasks, and I think that's the slide that you can see up at the moment. It looks like quite a light task load, but that gives you an idea of task load and the type of tasks that are mounting up for the organisation. Another thing that we've got as well is a ward acuity live flow, which is really useful as well, and that gives us vision at any one time of where the tasks are, or where the issues are, including admissions and so on. So we've deployed in the daytime. Our organisation together is about 2,000 beds between two sites, and on each site we found that having about 6 extra doctors on each site devoted to Hospital at Day has really been able to decompress the teams, allow them to focus on decision-making activities, and we are able to mop up the tasks that interfere with their decision-making flow, helping promote patient flow, patient safety, but also increasingly as well-being. So doctors still need to get to teaching, still need to have breaks, and so that's what we've been doing with Hospital at Day, and they can access the help directly now through using a handheld device via Nerve Centre to make their workload visible to us.
And I've got another screenshot here, Steve, as well. That's probably one that Jeremy would talk about.
Probably is. I'm afraid I can't. Let me just. Is it? I'll see if I can make it look bigger on my computer. Yeah, I think that's a Jeremy screenshot.
Yeah, this is. I think all basically Jeremy's trying to get out over here is that how the task is routed and how you set it up. So I think his point being here is about showing other customers that have hospital at night, which we have quite a few, how you have one profile for night time, which is, and then you have another profile that's set up. I was aware of this from some things that you've done on social media, and we also had another customer do something similar, but not quite the same. That whereas they removed all doctors off the wards during COVID and put them into a pool,
yes,
to then allocate the work. But this, I think, is a model, and I'd love to follow up with you and see if any more of our customers who've got hospital night would be interested in looking at this as a longer term approach. I think this is something that's got real benefits, you know, to get those patients reviewed and tasks move forward that you know, could help with lots of things, not just sick patient, but you know, getting people home, giving you capacity. So sorry guys for talking over everybody else. I'm just really passionate about this. I think for all the customers that's got task management or hospital night, you might not have an extra resource, but I think having a view of what you can do, and the previous screenshot I think is the one you were talking about, Steve, which is about looking at, you know, a ward acuity. It's got some metrics on there. Might not be the same for everybody, but you know, you've got targeted things that you can go and help with if you've got no task, couldn't you?
absolutely.
You know, today needs a TTO, even if they've not asked. So is there any questions from any questions from the wider people about this? Because I think this is the way forward.
Someone from Nottingham.
Hi, Mark. You're breaking up really badly, Mark. Yeah.
Of where Nerve Centre came from, really, when we started with the task management system, because oh, sorry.
You're breaking up quite badly, Mark.
Right, can you hear me all right? Rubbish networking now. I'll get somewhere. Come back in a.
Oh, that's better. It might be just when you got your screen on.
Just while we're waiting for Mark to come back, Steve, can I ask you a question? That's all right. I'm just curious about how you manage the difference between the parental team ownership and this team coming in and doing those jobs and tasks. If there's any conflict in there, or is it all really well received?
So yeah, obviously with any introduction of any innovation that, you know, brings about a degree of sort of teething issues, and we've had teething issues. But by and large, it's been extremely well received, and the feedback's been very, very positive. It just allows you to use your resource much more sort of effectively, and you can point out to, obviously it's a different way of working. And so long as they understand how to access help, how to use Nerve Centre, which we support as well, then they can soon start to reap the benefits of it. You know, in particular, you might point out that they're very short-staffed, and they might point out to you, why don't you just give me one of your hospital at day doctors? Because we've got the hospital at day doctors grouped together as a team. And that's deliberate so that their well-being is kept front and center as well, so that, you know, they're working together and that they're benefiting from that. But yeah, why don't we just dish these doctors out? Because we are short, and when you're short, you need to make sure that when there's a spike of work on ward A, that you go and deal with that spike. Sometimes that needs 3 doctors to clear the task load. But that might settle quite quickly, but then it's ward B that really needs you in the afternoon. Now, if you've deployed a doctor that's stuck on ward A all day, it takes a lot of negotiations to move that doctor to the next ward. But if you're focused on if you've got vision of the task load and people are accepting of this idea that that you've got vision of ward acuity, then actually it's pretty easy to get buy-in.
I think I'm just going to bombard you with questions to you. I've got 2 more, if that's all right. What are the grade of doctors on your hospital day team?
So currently F1 through to CT2. We had registrar presence a dedicated registrar presence for the hospital at day team for launch, and we're looking at getting a sort of permanent registrar presence to sort of lead the team. But that's not something that we've got in place at the moment. It's something that would be attractive to us, but at the moment it's running well as it is. Yeah.
And my last question is, I'm just curious about the junior doctor experience, especially on those who are in training posts, and whether you anticipate any impact on feedback from training opportunities or anything like that during those guys' time at hospital day.
Okay, so the first thing to say is that the Foundation Doctor Programme Directors have looked at hospital at day in a very favourable light, because there's a lot of training competencies that can get signed off through the tasks that are being allocated, and they're things that need signing off. So there was only 1 or 2 things on the entire syllabus that wouldn't be covered in a hospital at day sort of related activities. So that's the first thing to say at foundation level. I think as you get sort of higher up, then if you're going to go and see sick patients, then you can argue that covers there's some educational value for you higher up. I think, though, the key thing to do is to remind people that the training it actually enhances training opportunity for the doctors on the wards. Why? Because they might complain that the very tasks that they're uploading to the raising on the system are not educational for them. And so therefore they are effectively shifting them to hospital at day and which allows them to get on with the educational activities or the activities that they're finding more educational. It allows them to get away to teaching, which is often a problem that doctors cite. And so actually overall as a package, I mean, even when we're looking at rostering to hospital at day from the main rotas, the commitment on a sort of weekly basis was, I mean, we're quite lucky in that our workforce is quite large, but we're looking at a 1 in 16 commitment or less, and that was when we were at peak. So you get a lot of benefit from a little bit of sacrifice, and I think when people understand that, okay, now's my time to help out the wards, but I'm going to be reaping the benefit of that for the next 15 weeks, then it's not so bad.
Cool. Is my audio back on?
That's better, yeah.
Brilliant. I'll just go for audio because I'm in a bit of a mobile spot. So I mean, I think the point that Steve makes are all very well made, and I think this really goes back to sort of the foundation of where we came from with Nerve Centre 10 years ago, with the development of hospital at night. It goes back to that understanding of what the tasks are that need doing and who's out there to do them, and to extend this into the day, a bit of a major step forward for NUH, which is it's an enormous entity across 2 campuses. And I think certainly because I'm now divisional director for medicine, and I can't tell you how good it is to know that we have at least somewhere or some method to to deal with the peaks in tasks that happen during the day that we've always known happens. But when you've got one F1 and two F2s off on teaching, and there's 9 TTOs to be done on a ward, there was previously no mechanism at all to deal with that situation. So a day from a managerial perspective and from a sort of medical leadership perspective has been incredibly helpful over the last few weeks to really sort of smooth out those tasks. And I think that, of course, this is a major change in the way that doctors work, in terms of doing some of those tasks that aren't quite so helpful for training. And I think there's a balance to be had. And although you can certainly say that the weeks or the time that doctors have spent on the day team may well not be overly training productive, it does release and allow everyone else to get on with the job that they want and need to be doing.
There's a lot of people on this call who have hospital day. Has anybody ever considered looking at something similar to what Nottingham have approached? By the silence, that's a no. So it must be a very, very innovative thing you've done across in Nottingham, and some of those works that have happened. Questions for Mark or Steve? I go back to my advanced life support instructor head. I'm going to count to 10 and then move on to something different. So that's 8, 9, 10. All right. So it sounds to me like a really innovative piece of work that I'm really keen to understand more about and the wider impact as it progresses during wave 2 and over the winter and beyond. So I look forward to catching up more with these guys and understanding a little bit more that's coming out from those things. Our next speaker is joining us at past. We've got a very clear spot because she's working clinically today. So we've got literally a couple of minutes of waiting for Kath Higgins to join us, unless you're already on, Kath. No. So I'm going to puff a little bit while I wait for Kath to join. I'm going to, unfortunately, this is a bit cruel, pick on somebody on the audience, if that's all right. And I'm really keen to just have a quick little chat about Anne-Marie Pascoe. Are you there from Royal Cornwall?
She should be here somewhere.
Yeah, I like that, dropping somebody into it. I think I can see it. I'm just curious because I know there's been a lot of work happening at Royal Cornwall about COVID assessments and the such, like whether you want to spend a few minutes just sharing some of those experiences that you've gone through so far.
Sorry, it's Lisa, one of the project managers, just while Anne-Marie finds her microphone. We originally built a critical care assessment, essentially to help us guide which patients really did need to be in IT if it came to the point where we had too many patients to fit in, essentially. We actually didn't need to go live with it in the end. Our numbers down here weren't maybe as bad as elsewhere around the country, so we were lucky in that sense. But at the moment, we are currently working on a lot of our live flow pages just to sort of show us which patients need to be re-swabbed, depending on how many days they've been here and when their last swab result was, etc. So we've pulled in the swab result from our lab, and it just displays that as a negative or positive free text with a date. And then from really from the length of stay, we make the assumption that every patient is swabbed on arrival, and then 3, 5, and 7 days after on our command and control, it just says, you know, consider these patients for re-swabbing today. So much really as we've used it for COVID-19. At the very beginning, we built a page that showed where our next areas and current areas were for admitting medical or surgical patients, male and female, because our clinical site coordinators who manage our bed base and our incident control centre are based in 2 separate places, obviously to reduce the risk of us having problems down here. So it was really good for them to keep up communications, a nice simple approach, obviously billing in real time as well. Yeah, it was really good for that.
Thank you, Lisa. Mark, you got your hand up.
Unintentionally, sorry.
Oh, that's a shame. I think I had a wonderful question to ask. Okay, let me just see if are you on? I'm going to say no. And is Jeremy back? Do we know? Jeremy?
No, Mark or Sharon can take this bit if I share the screen. So there's Sharon and at Nottingham and Mark. So if I share the screen again, are you happy with that?
I'd be thrilled.
Right, let me share my screen again. And Southend have actually said they're looking at extending their hospital at night, which is cool. So if Mark or Sharon are happy to talk through the slides, that would be awesome, because this is what most trusts could do with mostly with clinical noting, which I think nearly all of you've got. So Mark or Sharon?
Debbie, I'm struggling with video, but what have you got up there?
The first one is the COVID overview slide. It's got the current COVID inpatients.
Yeah. So what we did pretty much from the outset of COVID is we wanted to use Nerve Centre to track these patients from the moment they hit. We have a number of different ways of doing that, some of which is manual, some of which is automated. We've linked our lab-based systems from the COVID PCR swab directly into Nerve Centre. So when a swab comes up positive, that immediately tags a patient. But we've also put in manual clinical notes, which allow people to say that a patient is suspected, or we've put in automated timers on those, so that when someone's 7 days post admission, they get a flag to get a reswab. And also at 14 days, it says that they can no longer require isolation. So what we've tried to do is automate as much as we possibly can, a system that allows us to have an oversight of everything that's going on in the hospital. And I can't stress enough how important this has been in planning and understanding how COVID is developing at NUH. We've got we have a 10 a.m. and 2 p.m. instant meeting, as I'm sure many of the trusts around the country have, and this is the data that is feeding that literally minute to minute. So people aren't scrabbling around with whiteboards and bits of paper. Anyone anywhere can look at this live flow and just see where the hotspots are. And it's actually fascinating epidemiologically to see the left-hand side of the suspected become lower and lower as a wave comes through, and the right-hand side getting higher and higher and then drifting away. And there's certainly we've been able to map that admission, then base ward, then critical care flow, which has helped us understand where these patients can be and should be, and it's helped us open and close wards at the right time to deal with the demand. Sharon, I don't know whether you want to take them through anything from a data perspective, but this has been absolutely the epicenter really of how NUH has dealt with COVID, and we couldn't have done it without Nerve Centre.
I know Sharon's on mute.
Oh, sorry. Can you hear me?
Yes, yeah.
So the previous live flow, we've been using that in order to populate the national returns that are leaving the trust as well. So whatever numbers we're seeing in trust, it's reflecting what's being sent out nationally. Okay. Based on the Nerve Centre data that we've been collecting, we've been able to produce a number of dashboards. So this one is a bit of a replica of the live flow that's in Nerve Centre. Now, this one we've split out just to kind of refresh every 10-15 minutes, just to show the number of confirmed suspected cases we've got, which is shown on the previous slide. But also, we've been able to put in factors to show people the number of confirmed that we're having in the past 24 hours. And again, also been able to display the death numbers as well. So bringing through our PAS data and our Nerve Centre data to be represented in a click dashboard. Thank you. Okay, so this one is based on our bed. So in Nerve Centre, we've been able to tag a bed as a COVID bed, a green or yellow or purple bed. So a COVID blue bed is our COVID beds. Our yellow beds are suspected beds, and green are where a patient has been tested negative, got a negative result. They've been able to put back on a green bed. So again, on here, operationally, they're able to see where the capacity is, where they need to open or close certain beds or move certain tags to certain other beds. In other pages within this dashboard, we've been able to show data quality wise as well to ensure that there are correctly got the right patients on the right bed, making sure that we've got a positive patient on a blue bed and no one else. So all of that data we've been able to display in this dashboard as well. Thank you.
I think that was it from,
That's it. Thank you.
from the slides, Sharon, unless there's any wider conversations. But
so I hope I've managed to sort out some Wi-Fi finally. One of the additional things that we've done is because we can use OBS data as well to work out how much oxygen people are on, we're able to give us an idea of oxygen usage across many of our wards. We've also got a dashboard that tells us how many of our COVID patients are still on non-invasive, still on oxygen, maybe home today. So we basically tried to get that really comprehensive understanding of where our COVID patients are in the hospital, drawing on all of the data sources that we have in within Nerve Centre. So it really is a kind of comprehensive, real-time understanding of what we're doing, and as I said earlier, hugely helped not only our planning in terms of day-to-day management of the hospital, in terms of the operation side of bed management, but also we've used because this data is such high quality, and we've teamed up with both Experian and Aon to do some absolutely extraordinary predicting work using their knowledge of epidemics and pandemics. So as I say, this is something we're using in real time, and also to give us an idea of how many wards we're going to need in a week's time or 2 weeks' time as well. So if anyone's got any questions about that predictive analytics, then happy to take those as well. There's a lot of noise in the background. I don't know if that's me or someone else.
That's me pinging away in the background. I think it's other people doing, but pings on me. Just before Jeremy comes into anything, I'm conscious we've only got Kath Higgins with us for a short period of time. So if you don't mind, could we just pause the questions there, pass across to Kath to talk about work around COVID and diabetes, if that's okay. So Kath, can you hear me?
I can hear you, yeah.
Fantastic. You should have the option to share your screen at the bottom of your page.
Yeah, I'll have a go.
Let's go. Great, Kath, we can see your screen.
So I'm going to try and make it the whole.
There we go.
How's that looking? Does that look good?
That's good to me.
Yeah. So I'm just going to talk to you for 10 minutes really about what we've been doing with diabetes in Leicester for inpatients, focusing on what we've done during the COVID pandemic. So I'm going to talk to you about the rapid implementation of a virtual inpatient diabetes in-reach service. I'm the clinical lead for inpatient diabetes care at Leicester. So obviously the COVID pandemic introduced significant challenges for all teams working in hospitals, and has made us think about different models of working. The diabetes team has been faced with issues of redeployment, and again, as have many other teams. But when faced with looking at how the team was working, we needed to look at new ways of working to ensure that we maintain safe care for our patients with diabetes. And that really was one of the key priorities in March when COVID numbers started to rise, how we could keep our inpatients safe, as well as sort of face the challenges of redeployment, etc. So there's quite a lot on this slide. I'm not going to go through all of it, but really it's just to say, and many of you will be familiar with this, that there are particular challenges with COVID and diabetes. We know that a third of COVID-related deaths in the first wave were in people with diabetes, and people with diabetes are 2 to 3 more times more likely to die with COVID. And there are particular pathophysiological challenges in COVID and diabetes around glucose control, which are exacerbated around dexamethasone as well. And so it's a real priority that we were able to.
Can I just interrupt you for one second? Can people go on mute, please, if they're not talking? Please, thank you. There's a lot of background noise. Thank you. Sorry, Kath, my apologies for interruption.
Okay. So I think this just gives you the background as to why we felt so strongly that we needed to do something to ensure that we had a grip of what was going on in terms of looking after our inpatients. And so what did we do? Well, when we went into lockdown in March, within probably 5 days, we were challenged with reorganising our team, and we switched to a completely virtual inpatient review service. So previously we had a roving service which was quite reactive to the patient's needs, but we were limited in terms of how many patients we could see, because in terms of it was only in the time you could walk around the hospital and see so many patients. So we made a decision to switch to a fully virtual review pattern. All reviews between the end of March and the beginning of August were undertaken by a virtual model. And our aspirations were that we would review virtually every person with diabetes in hospital, and prioritising the COVID patients for consultant review. So why did we do it? Well, I think everyone was faced with the same problems. We had to scale up our capacity in order to keep on top of the numbers of people coming in with COVID. We had to minimise exposure of staff to COVID, preserve PPE for the frontline staff. We really needed to ensure that we were getting the highest levels of care for people during the pandemic. So how did we do it? We organised the team, as I've said. We looked at the whole MDT and looked at everyone's responsibilities. Team of consultants were moved specifically to managing InReach over Monday to Friday. And the DSNs led the 7-day service with a clinical aid. And this is where using Nerve Centre really came into its own, in terms of being able to get real-time data as to where our patients were and some of the observations and information, and being able to review that in real time every day with the whole MDT. So we triangulated the data that we were getting from Nerve Centre, from EPMA, and from our results system, ICE, and some of the other data reports we get on high-risk drugs and datixes related to diabetes. By triangulating all of that information, we were then able to provide virtual reviews. And so, well, how did we use Nerve Centre to enable this? Well, for example, this morning I've done my virtual review ward round, and I've got my list of patients on the desk next to me. I haven't actually counted them up because I was just finishing as I joined this call. I've probably got about 35 patients on my list from this morning. So we would start our list. We would, using Nerve Centre, identify from the real-time list the COVID positive patients. We also have lists of people with diabetes and people who are treated with insulin. So each clinician may choose a slightly different approach, but by using the real-time lists available to us, we can start off with a list of patients in hospital that day. So I usually start with the COVID positive list for the site that I'm covering, and then work through that, looking at the patient detail. And it's a bit busy, this slide, but when we click onto the patient list for those areas or those lists, we can automatically see who's got COVID, who's got diabetes, who's on insulin, and then I can see which of the patients that I need to review. So I'll work through that list, through the list of patients identified on Nerve Centre. Looking again, as I said, at some of the other reports we get. So we get daily data reports from Nerve Centre EOBS on blood glucose levels. So people with a blood glucose level less than 3 or over 25. So I'll be looking at that at the same time. And then looking at the data that the ward teams are entering. So that they'll be putting information about nutrition, the news score, there may be something on clinical photography. The whole MDT will be putting things into the handover field. And then looking at the patient's blood sugar results, we also have a blood ketone field in Leicester, so we can look at, so nurses will enter both blood glucose and the blood ketones. And if need be, supplement that with a phone call to the ward, but it's rarely required. That we can normally triangulate enough information to make a sufficient review. And so finally, once I've reviewed all the information, then I'll enter the plan in real time into the MDT window. So this is just an example of a brief plan that I entered a couple of weeks ago. That goes straight in, I'll type it in real time, and then the whole MDT can see that from the minute it goes in. So how many patients have we been reviewing? Well, as I say, we can probably work through 30 or 40 patients in a half-day session, and these are the numbers of patients we were having admitted during the pandemic, the first wave of the pandemic. So our diabetes bed occupancy ranges on a daily basis up to 300, maybe 350 prior to the pandemic. It dropped during the pandemic. And then our inpatients with diabetes and COVID, monthly admissions during the first wave peaked at around 250 patients in April. So this is the sort of number of patients that we were able to review by using the data we were gaining through Nerve Centre and EPMA, etc. So I'll just finish off by saying, because there was a lot of concern about whether it was safe to switch to a fully virtual service, and so we've been looking at our SBC run charts and the data that we collect to ensure that what we're doing isn't creating harm, because obviously we wouldn't want to switch to a fully virtual service if we thought we were going to introduce any risk of harm. So I think in the interest of time, I'll just say that we do collect a lot of data, and we have been doing over the pandemic, and there's no evidence that running a virtual service has been harmful in any way. We've not had any increase in significant harm events, which we report nationally. All trusts have to report diabetes harms nationally. So in terms of looking at people with hypoglycemia, hyperglycemia, or percent of blood glucose in range, there's no evidence of harm. In fact, certainly for in-range blood glucose readings, there's a slight increase. And in fact, we pick up and we're able to feed back to teams more, I suppose, things for learning. We pick up nuances, or we're able to feed things back to teams in real time. I'll flick through these. So in summary, by using the real-time data that we get from Nerve Centre and triangulating that with data from other sources, we've been able to introduce a fully virtual service through the first wave, and then we've just last week switched back into the fully virtual service. I'm sorry, but my dog is barking ferociously, if you can hear him. We've just switched back into the fully virtual service in wave 2 last week, and there's a lot more that we can do with this to make, and we are reassured that the model is safe. And I think that other trusts could easily roll this out. You know, if they were looking at reorganising, remodelling their service, and I think they could be reassured that this is a safe model of care for inpatients with diabetes. But I'm going to finish now. I'm sorry if the dog, if you could hear the dog, but that's all I was going to say. I hope that that's just given you a flavour for some of the ways that, you know, that teams can reorganise and use this information. It's really, I mean, to be honest, it's transformed the diabetes care over the COVID pandemic, because we can review so many more patients by using this model. At the peak of the pandemic, we were reviewing 200 patients a day with diabetes. Not all of those had COVID, but everyone with diabetes in the trust had a virtual review.
Thank you, Kath. You please know I couldn't hear your dog in the background.
Oh, sorry.
That didn't come through to me. That's good. I couldn't hear. That's a good thing. I'm going to ask other people in the audience first if they've got any questions first of all for Kath, because as always I'll have a couple. So open up to the audience.
Hi, I have a question. Mike Whiteside from Doncaster. One of your slides earlier showed the input that you wrote about that particular patient. I'm just intrigued to know which part of Nerve Centre is that going into, because currently we don't have any clinical noting turned on as yet, but I presume you need to have that turned on and in use before you can actually start doing virtual reviews.
Yeah, so I mean, the first thing I'll say is that I'm not at all technical, so Paul can always interject, or Debbie, but I put my advice into the MDT window in the handover field, and so it goes. We don't have a specific window for the diabetes team, but we are going to. That's going to go into test fairly soon. But I put my advice in the same field that, say, that the MDT team inputs into it. It's called MDT stroke discharge, and the ward team. There's quite a lot of information in there, so the ward team do look at it regularly, because it's the window that most people seem to enter information into.
But Mike, this might be linked to some of the things you've been looking at case notes, or where this is slightly different. This is using the handover profile or the traditional handover profile.
That sounds really good, actually. Did it take a while for people on the wards to realise that there was stuff in the handover profile?
Yes, and to be fair, I think there are still people who don't know. It's an ongoing. We're still having to remind people to look, but most ward areas now, particularly the COVID wards and the acute areas, know that we are looking, doing the virtual reviews, and that we will be putting stuff in that window. And as I say, we're currently just working on getting our own window or field, whatever you call it, in the handover, which will be called Specialist Diabetes Review. And so I think that will help as well, because people will then start, and we'll put some comms out. They'll know that there is a specific window and it will be there, and they need to look for it.
Brilliant, thanks.
Any further questions for Kath from the audience?
I can't see the chat, Paul, so if there's any questions in the chat, I don't know if any.
Not in the chat in relation to this, no.
Yeah, I've not seen any.
Well,
I just wanted to say, oh, sorry, Paul.
It's okay, carry on,
I can't help myself. I'm off today, and Paul's like, just why don't you take a day off and leave me alone? Kath, I obviously have been closer to what you've been doing at Leicester, but not had the full brief there. And like you say, it's a lot evidence based. I think that's awesome. And again, simple. Some effort, but simple for other trusts to be adopting those things. And whilst I'm not clinical anymore, I know that the patient outcomes with diabetes and COVID is an impact. So there's lots of things there for the guys on this call to be considering. With not a lot of effort getting big gains. So are you happy if we share your slides, Kath? Is that okay?
Absolutely, yeah, I'm more than happy, yeah. And if anyone's got any questions afterwards, or if there are any, if conversations happen afterwards with diabetes teams within the trust that anyone works in, I'm more than happy for diabetes teams within the trusts to contact me if they want to know anything more about what we've been doing, because as I say, it really has transformed the way we've delivered our care. In Leicester, I feel a lot more. I feel absolutely reassured that we do get to see a larger number of patients, and the patients that we need to be reviewing.
But Kath, it seems to me that you're using some really rich data that's being held in Nerve Centre by your staff at UHL, not your staff, but the staff at UHL.
Yeah.
I'm just curious, are there any wider plans to do something similar with any other specialties at UHL?
Yeah, I don't know that, to be honest. No. Yeah.
Just see, like Debbie said, it sounds like such a relatively simple process that could be upscaled relatively quickly to other specialties if it's needed from that perspective. Okay, last call for questions for Kath. Okay, Kath, in that case, I'll thank you very much. You can go back to your clinical work that you were doing. Thank you for your time, much appreciated.
Thanks a lot, thank you.
Mark, I'll go back to you, mate, because I rudely interrupted you mid-flow to bring Kath in.
That's fine, no problem. I was just where do we leave it? I think I'm just going to share hopefully something useful, which just gives you an idea. Actually, I think Kath just needs to stop sharing, if that's all right.
I'm trying to just leave the meeting, but I can't find the way of. If someone can eject me from the meeting, yeah.
We'll find a way. We'll find a way, Kath.
Yeah, I'm leaving it now.
So I hope you can see that. So so this is the back end of all of the information that we're pulling into from Nerve Centre to just give us an idea of where our patients are, what specialities they're under. This is all complete live and real time, as you'd expect. And then the bottom ones, you can click on all these buttons and get the list of the patients. So it gives you an idea of how many of them are still on oxygen. We're using EOBS data for that. We're using EOBS data for the EWS greater than 4. We're using handover data for medically safe and home soon. And we're using our fairly extensive handover and ICE integrated discharge team assessments and development around the supported patients. So it just gives you an idea of how once you start having this sort of bulk of data behind any system, when you add COVID to it, you can start connecting the dots. So just thought I'd just share that screen just to give you an idea of what we are trying to pull together. Again, this is being used on a 3, 4, 5 times a day basis in order for us to plan and to understand what capacity we need. Just thought I'd share that with you. And if anyone's got any questions, feel free to ask.
Mike, your hand, it was a legacy hand. Yeah, okay.
Mark, if you could leave it on the screen for a second, if you don't mind. I think while people are just looking at it and thinking of their questions, because again, for me, completely not clinical, appreciating that this isn't Nerve Centre that you're looking at. This is ClickView, as Mark said. You know, the tabs in the bottom, or what, they're not tabs, but the 8 boxes or 10 boxes across the bottom is just gold dust, having that information at your fingertips. Well, 8, isn't it? You know, not just about the sickest patients, which is clearly really, really, really important, but you know, how many patients are, you know, your COVID patients are going home, how many have you got on an IV, all of that thing. So anybody, sorry Paul again, anybody, any questions on that? I think the biggest piece of information on there that's not directly well, it's took from Nerve Centre, but we can't currently show it on our live flows, is the oxygen. We've already got a JIRA raised, so that we can support that in the future. So let me ask a different question. Sorry for taking over, I just can't help it. How many of you as organisations have got that level of data real time in the trust? And how many of you have got different things? So if you haven't got that, what have you got? This is about sharing, guys. The purpose is obviously giving you some examples of what we've seen and what Nottingham are doing, what Leicester's doing. Royal Cornwall's had a few minutes, but what are you guys doing?
Hi, Lee from Doncaster. We've got a COVID screen and quite a other bit of stuff. Would you like to just see our COVID screen?
Lee, that would be amazing.
Just give me a couple of minutes. I'm just going to go back on mute and then just open Nerve Centre on the laptop, because I've not got that open at the minute.
Yeah.
Give it a few minutes and I'll come back on.
I'll jump in quickly while Lee's doing that. We're relatively early on in our Nerve Centre journey, despite apparently being with you forever, it seems. So since we've turned on e-observations in DRI, Lee has been working really hard, collating all that data into live flow and presenting it in a way that is now useful to us. And have to say, from Lee's perspective, it's been a very, very steep learning curve. But the stuff he's pulling out for us is, as Debbie says, it's like gold dust, really. We didn't really know what it was we didn't know, and it's clearly very good from an operational perspective.
So Debbie, one thing that I didn't mention earlier was that we have some. I think there's a number of NHS hospitals in a similar position where oxygen flow to different parts of the hospital is limited. So we're using the Nerve Centre basically FiO2 rates to estimate the amount of oxygen that each ward is taking on. Some of our wards are pretty critical from an oxygen flow rate perspective, and that's really helped us understand where the demand is and for to get our engineers to make sure that they are focusing their efforts in the right place. So I mean, that might seem like a bizarre of what is effectively a single tap on an EOBS data entry, but it's been incredibly useful to us.
No, and actually, Mark, while Lee's bringing that up, we had several trusts at the beginning of this asking for some oxygen flow. So if there's anything offline, you can share of how you've done that. I'm sure lots of trusts will find that really useful.
So that's our. Am I off mute now? Yeah, that's our dashboard. We've got an oxygen one as well because we got into a alerting system that our oxygen was running pretty low on the Doncaster site in particular. So we've got a dashboard for oxygen as well, which is just, it's the data along the bottom, the number ventilated on CPAP and oxygen in particular wards which are close to each other and using high flows of oxygen that helped our estates department, I think, realise whether things were getting better or worse. We didn't fail on the oxygen front, but it looked quite close at one point. So we've got 3 sites, 2 of which have got intensive care units on, and Montague. The next site is more like a rehabilitation place, but has had lots of COVID out there just because they've been elderly patients as well. So I've just split it down into patients that are within critical care, and of those which are ventilated, CPAP, high flow oxygen. And then we've got some down on the wards. We're quite unique, probably in Doncaster, in that we have respiratory wards where we CPAP patients as well. So our critical care numbers have been in line with our neighbouring trusts, but then we've had, up to 15 CPAP patients on the Doncaster site within the unit, and we've currently got 5 there on a ward in a very small DGH in Bassetlaw. So we've had it quite bad, really. We've just been masked in terms of the reporting numbers in critical care. We were reporting quite low numbers of patients on oxygen to the NHS England, but our numbers that we were pulling in from Nerve Centre told a different story. So we're still trying to tie up these issues with our information department, so the data going into NHS England's more accurate. But I've got a call about that later. Actually, we used, rightly or wrongly, we used the past visits as well to kind of to look at what the trend had been. So we've got you know, some past data there as well, going back to March, telling us what the trend was for each month, what the totals were for each month. If you've got any questions on any of that, guys?
That trend by month, it's really interesting, isn't it? Because when you think of the, even if you take into account where things like lockdown came in, when it starts to slip away, you can see what those meant to your NHS hospitals.
Oh yeah, I mean, October was a really busy month. It rocketed up, and then November's been worse. I've not put November in there because we've not finished the month, but I've got a program called Power BI that's pulling the data from the warehouse now, and that's giving us the trends, and it exactly, you know, mirrors this really. So yeah, accurate.
I think that's one of the points that we've learned from COVID is just because of the extraordinary granularity of the data set that we have, and I think this is probably true of a number of nodes and sites, that the accuracy, timeliness, and the quality of the data is such that it's better than any other data that's going out into almost up to government level. So we're, as I say, we're working with a number of external partners on what that means, and our ability, once you've got that quality of data, you can do some extraordinary predictive analytics, and I think that's the sort of realm that we're all moving into now. We've got to use the data not just to tell us where we are now, but where we're going to be in a week's time, 2 weeks' time, 3 months' time, and you know, that's really where. But you've got to have data that's accurate enough that you can put your hand on and say, yeah, I believe that, before you can move into that sort of area.
So this is the dashboard. Our CPAP and NIV services is primarily physiotherapy and critical care outreach led on the wards. So this is just the Doncaster and Bassetlaw breakdown of patients that are on CPAP and NIV. Obviously, there's still, this time of year, there are a lot of patients on NIV that have not got COVID. They're just exacerbations of COPD, but we've still got quite a few. 10 patients who are COVID positive at Doncaster that are on a respiratory ward that are on CPAP. So the numbers are still causing us enough work to keep us busy in the day.
Excellent, thank you, Lee. Anybody got any further questions for Lee?
Yeah, thanks for live flow. Thanks for your help, Paul, as well. Getting the brain around live flow.
Yeah. Once you get your head into live flow things, just reiterate what Mark said, that the power of it is incredibly powerful tool for real-time data. Absolutely. Thank you, Lee. You can stop sharing your screen now if you want.
Thanks. Yeah.
I'm just going to pull in a question from the chat from Angela at Esht about same-sex accommodations. I'll read this out verbatim. Interesting how same-sex accommodation breaches can be gathered without manual inputting and a monthly report pulled so that we can submit in line with national guidance.
I've already answered it, Paul. Sorry, and after
apologies.
Yeah, sorry, because it's not COVID related, and I reach out to her offline. And I think she's actually dropped off. So all the ones in the chat are answered. Sorry.
Fantastic. That's okay. Communication is the key, isn't it? It's the key.
Yeah.
So the kind of part of our agenda now is just a Q&A really, and some conversations. If anyone has anything else they want to bring to the table for discussions or sharing.
So we've got somebody. We've got Levi Larkin. I'm not sure which trust, because if we know what trust, we can put you in touch. So where's Levi from? Okay, Luton and Dunstable. So Lee, we've got someone from Luton and Dunstable that would like to be put in touch with you. Is that okay? think Lee's. So we're putting Lee. We've got someone from the region of Dunstable that's wants to look at what metrics have you used for your live flow.
Yes, no problem.
So if you can't share it now, then we'll put you in touch together.
Yes, of course. Yeah, no problem.
Cool. So we'll take that action.
So there are some other trusts who've done some of the work that couldn't make it onto today. So if we can try and find some of the work, we'll put other things into contact. This is being recorded according to what we found out earlier on. We will distribute it, so you've got it for sharing if you want it for future things to look back to. If there's anything that you've seen or heard today that you want more information on around clinical photography or some live flow work or anything like that, please reach out to your accounts manager, who will then make some of the right connections within the company and take those things forward for you if you need to. Other than that, final opportunity for questions. Nope, we'll call radio silence. In that case, we'll close a little bit early if that's okay. Thank you all very much for your time. I hope you found it useful. And again, thank you for all who have spoken today as well. I found it really useful. I've got quite a bit out of it. I actually made loads of notes and things that I'm going to follow up on, and I hope you've managed to get some things out of it too.